Perfect. Hi, folks. Thanks for showing up. My name is Eric Autumn. I'm a professor in the Department of Biology, and I'm the pre-professional health advisor, and I know a lot of the students in this room. Normally, it would be Dr. Robert Nguyen who would be standing here because he really, in collaboration with MSU School of Human Medicine, founded this thing 15 years ago. This is the 15th iteration of the Your Health lecture series. And I've always been in the background, but this is the first time I've had to introduce, so I'm a little nervous. So over the last 15 years, we have had so many health professionals coming from Michigan State University. Remember the first one, I'm not going to be overly long here, was a Parkinson's disease specialist who came up and talked to us. And then allergies and nutrition. And now we're going to talk about opioid addiction with Dr. Poland here. And I couldn't be happier that we had this relationship. This has expanded, not only with Northern Michigan University, but also to include components with Michigan Tech, with Bay College, with LSSU.
Oh yeah, you're very wet.
Hopefully we'll expand beyond this with our relationship with Michigan State College of Human Medicine. So, with that, I would like to thank the sponsors, Michigan State College of Human Medicine, UP Health Systems, NMU, and the Superior Health Foundation. Thanks so much for being here. And I'm going to turn this over to Mark Brevy, who's going to introduce our speaker, who very graciously did.
All right. Well, thank you, Dr. Adam. And he stole a lot of my thunder because I was going to talk about, this is the longest run. No, you're fine. This is the longest running in the Your Health lecture series. And since it started here at NMU, we've expanded downstate at our Midland campus and Grand Rapids campus. And I knew it was at least 10 years because I've been with the college for 11, and I've been coming ever since I started with the college. So just to reiterate, yeah, we appreciate the sponsorship, the co-sponsors of Northern Michigan University, Michigan State University College of Human Medicine, UP Health System Marquette, and Superior Health Foundation. Also want to say a special thanks again to Dr. Robert Nguyen and Dr. Eric Adam for the continuing partnership. I will say, I know there's a Packers-Lions game that starts at 8:15, so I don't know how big of a fan Dr. Poland is, but we'll try to be prompt and be done at 8, but we'll stick around a little bit longer just in case if you don't need to jet out to get to the Lions Packers game. I will say at the conclusion, Dr. Poland will take some questions from the audience, and I also will say I am just so grateful for Dr. Poland to make the trip up here. She truly is one of my favorite people at the College of Human Medicine. She's heard me say that a couple of times, so it's not a shock. But I've gotten to know her over my tenure at the college, and you're really in for a treat for tonight. So with that, I would like to introduce our speaker this evening. Dr. Cara Poland is a recognized expert in addiction medicine. She is associate professor in the Department of Obstetrics, Gynecology, and Reproductive Biology at Michigan State University College of Human Medicine. She earned her medical degree from Wayne State University and was trained in internal medicine at St. Joseph Mercy Hospital in Ann Arbor, Michigan, and in addiction medicine at Boston Medical Center in Boston, Massachusetts. She received her master's degree in education from Boston University. She has an interest in educating healthcare providers and providers in training to improve care for patients with substance use disorders, particularly during pregnancy and early parenting. I could go on, but just to make sure we can get you to that Lions and Packers game, I will turn over to Dr. Poland.
I did hit 5 feet tall. I just want you to all know that. But I always have to move it down. Let me know if there's any problems with the audio for the virtual participants. Okay. Thank you so much. What Mark didn't also tell you is that we cross paths not only in our community-based work, but I have a little bit or maybe a lot of the advocacy bug. And so he also runs our government affairs work, and he is one of the people that I trust, which says a lot in politics, right? And has been the recipient of a 10 o'clock at night text message. So I was thinking, and that's, my husband will tell anyone that that is really dangerous if I start something with that. So we're going to talk a little bit about addiction medicine in communities. We're not going to talk a lot about individual substance use or treatments for substance use. I can provide you with that information as well. And then we're going to talk a little bit about advocacy. Right now, the state of Michigan is slated to receive $1.45 billion. That's right, billion dollars. Like our brains can't even conceptualize in the billions of dollars, right? Over the next 18 years in settlement funds. And I chair the commission that advises the legislature on how to utilize those funds. So we're going to talk a little bit about those and talk about the impact that individual advocacy, particularly from places of higher education and younger adults, how effective in ways that you might be able to get engaged in some of that system. And then we'll kind of use a little bit of my own personal story to hopefully get you guys excited about advocacy, because it is a lot of fun and it is a huge responsibility that you will have as a future healthcare provider. I think everybody sort of knows that you're going to be in a clinic working with patients, serving individuals, but there is a huge amount of public health need, and also the need to elevate the voices of those that may not be able to speak for themselves or maybe are disenfranchised by the systems that we work and that we live in. So we're going to talk a little bit about addiction in the community. Because we're talking to an audience of undergraduate students, I'm going to give you guys a little bit of information on alcohol, because I know that if I do a brief intervention as a physician and give you advice on alcohol consumption, in 6 months from now, if I come back and survey you, you will have decreased your alcohol consumption by 50% if you take my advice. So that's a really cool fact, because you don't think about, what do those 2 or 3 sentences that you say to somebody, what impact could they have as a clinician, as a nurse, as a physician? So here's my story. So has anybody really wanted to go to a party on Friday night? And so they've planned their week, right? I'm going to study on Wednesday because I've got an exam on Monday so that I can go out on Friday night with my friends and drink, right? So on Wednesday night, you study hard, you get a nice 8 hours of sleep on Wednesday, you get 8 hours of sleep on Thursday night, and then on Friday night, you go out and you go to the party, right? You lose 40% of what you learned when you go to that party on Friday night and have 2 or more servings of alcohol. 40% of what you could have retained has been lost. 2 days later, isn't that crazy? Is that remarkable? Does that make you pause? So what is a serving of alcohol? Well, how many servings of alcohol are there in a bottle of wine? It's okay to be wrong, I promise. 10. A dozen? Is that what you said? 16. 7 to 8 in a standard bottle of wine. If you go to a restaurant and they pour you a glass of wine, provided you're old enough to do so, those servings are usually about 2 servings per glass of wine. So one thing that has changed a lot when it comes to alcohol is we have a lot more craft beers on the market, and those tend to have higher alcohol content. So 1 beer is now more than 1 serving of alcohol, compared to if you look at kind of an older, Budweiser or a more traditional beer. Do you need to sit down? Come on, there's lots of seats. It's okay. It's okay. We'll just wait. Awesome. There we go. Okay. So I promise I don't bite usually. I mean, who knows? Could be scary. So when you think about the effects of alcohol on the body, they actually last much longer than just that intoxication, and they affect things that happen both before as well as after. And so what is unique about the US culture in the college age group is that we really have normalized binge drinking. So what is binge drinking? For a female, it's having 4 or more drinks in a sitting, and for a male, it's having 5 or more drinks in a sitting. The reason it's different for males and females is because the male stomach actually has alcohol dehydrogenase, the enzyme that breaks down alcohol in its first step, in their stomach. So they just don't get as much alcohol into their body. It doesn't have to do with body weight. It doesn't have to do with body fat percentage. Everybody has all these like fun theories about it. And I'm like, no, boys just make alcohol dehydrogenase in their stomachs. And then what's really remarkable is that everyone knows that once you hit age 65, men turn into women, right? It's like a known fact. They stop having alcohol dehydrogenase in their stomach. So drinking limits for the elderly are the same regardless of gender. And the studies were done in kind of a male-female dichotomy. So I don't know. I'm not trying to be like dichotomous. It's just that's the way the studies are. So when we look at people who are in recovery, when we look at people who have survive the disease of addiction and are kind of on the other side of it. I have a good friend of mine and he said to me, you know, what I love about treating people with addiction is that when they come out on the other side, they're actually better people than they would have been if they'd never had an addiction. Recovery is real. It's pretty remarkable to watch. I've been able to see people, you know, go from really being isolated, really not having a lot of social connection, not having a lot of, you know, friends, family involvement in their life to, you know, I have somebody who now, she actually works with me and she's 10 years in recovery next month. She's, you know, she's just like so delightful and full of energy and just really wants to do good in the world. And it's a lot of fun to watch people kind of progress through that. But one thing that happens when people have a substance use disorder is they often become isolated. So we've talked a lot recently over the last few years about social isolation, right? You all were in high school, right? When it really, really sucked and all you wanted to do was leave and not be near your parents and your parents were right there and you couldn't leave. Sound about right? It sucked. Don't worry, it also sucked for your parents. Do you want to know what the largest group of increase in drinking was? It was parents of children ages 7 and younger during COVID. So you weren't the worst. It was actually your younger siblings that were worse. You can tell your parents I said that. So I'm going to talk a little bit about these famous studies from the 1980s. They were done by a guy named Bruce Alexander out in Vancouver. And they're called the Rat Park studies. If you Google search Rat Park cartoons, speaking of cartoons, there's actually, it's like, I don't know, it's probably like, I think it's 57 cells, but don't quote me on that. It might be like 60 some of a cartoon that kind of goes through these experiments. And so if you're interested in more information, that's a great way to kind of just get the general overview. So this guy, Bruce Alexander, he put these rats alone in a cage and he gave them the choice between plain water and water that had cocaine in it. And he watched how much water or cocaine water they drank. And what happened was the rats used the cocaine water to the exclusion of eating, to the exclusion of doing anything else in their isolated all alone cage until they died. And so that is how we got things like the just say no, the war on drugs. And so when we look at that, when we look at the programs that came out of that, things like DARE, did you guys have DARE? I might be aging myself, right? DARE, the police officer comes in and says, you know, don't do drugs or you'll be in jail. And then they're like, and then they make it sound like it's going to be like this guy standing by the playground with like this black trench coat who's like, do you want a joint? You know, and it actually doesn't prevent youth substance use, shockingly, nor does having like anybody have those big assemblies where they bring somebody in recovery and they're like, my life sucked and now I'm in recovery and it's great. I don't know why everyone in recovery apparently sounds like they have smoker's cough or I don't know what's going on with that, but and we actually find that actually encourages drug use because the high school kids are like, oh, well, that person did fine with it, so it must be okay if I do it, right? So we have to be really careful with prevention. But these are the studies that started some of that craziness. These are also the studies that were cited by the Reagan administration in terms of the in terms of the war on drugs, and then compounded by the Clinton administration. So don't worry, addiction is a bipartisan issue. We used bipartisan politics to create a problem. So now we have to use bipartisan politics to get out of it, right? And so during the Clinton administration, they did a lot of the minimum sentencing, and if you have so many types of counts on your record, then you automatically have extended sentencing. So the United States incarcerates more people than any country that reports in the entire world. The two countries that don't report, so we don't know if they incarcerate more people, are North Korea and China. So we incarcerate more people than pretty much any we incarcerate more people than any known country in the entire world. And so when we look at that, what are the impacts of that? So the two largest treatment systems in the United States are the Veterans Administration, and we'll get to why that is in a moment, and the Department of Justice. They're the two largest providers of addiction care. Let's think about that for a minute. How insane is that? It's not your primary care clinic. It's not the hospital down the street. It's your jail. Your local jail provides more addiction care than your hospital system. On average. I mean, I don't know specifically. Don't quote me on that. That's kind of scary, isn't it? But that's the way the system's set up. And then we have a lot of judgment and stigma, and we kind of take that in. And we tend to know that we tend to treat people differently based on what we think are their chances of treatment, what we think are their chances of recovery, what we think is maybe normal or not normal. Like, I don't drink on, if I have a big test on Monday, I just don't drink on Friday or Saturday night because I know it's going to cause me a problem. But somebody who has a substance use disorder might not be able to make that same decision, because if they don't drink, they suffer. Because they suffer with withdrawals. And what does withdrawal feel like? Withdrawal from alcohol use is, kind of the shakes. You can have seizures. You can actually die from alcohol withdrawal itself. Withdrawal from opioids feels like the worst flu that you've ever had in your life. What do you want to do when you have the flu? You want to go to bed and sleep, right? You also have the worst insomnia of your life. So think of the flu with insomnia. That sounds pretty miserable, right? And if you know how to solve that, you're going to try to solve it. And so how people sometimes solve that is they use the substance again. So I always tell people, like, if it was me, I would do it too, because it would solve the problem, and being in withdrawal is pretty miserable, especially if you don't have adequate, appropriate, safe, evidence-based treatment in your community. So Bruce Alexander then said, okay, so we put these rats in isolation, and we got them good and addicted, and we got them addicted, and then they died. And so just say no to drugs. So the next step of his experiments was he created Rat Park. It was like rat paradise. It had all the cheese a rat could want. It had other rats to play with, make families with, have sex with, all the fun things in life, right? And so it was like a rat paradise. And he said, okay, if I give these rats the choice, one of the reasons we use rats as a human model is because rats are social creatures in the same way that humans are social creatures. So he said, okay, so we're going to give them like social paradise. And then we're going to give them the choice between, water with unadulterated water and water with cocaine. And so the rats in the park tried the drugged water, but predominantly did not continue to drink it. There were still some rats that developed the disease of addiction, but the vast majority of rats actually tried the cocaine and said, no, thanks. I want the plain water. What was different? Community, right? The feeling of belonging, joy in your life. So one thing that happened in our world during, kind of in this general time period was the Vietnam War, and 20% of soldiers used heroin while on duty. So there was a lot of concern for reintegration given their clear addiction. So the VA did a ton of work to be like, hey, we got to treat this. We have to have the resources to treat addiction. So again, to this day, they are the single largest provider of addiction care in the United States is the VA administration. But what happened when people came back is 95% of the addicted soldiers discontinued use with no treatment after returning home. So active war zone with your family and friends does different things to your brain, right? So I question whether or not that's almost like the human rat park experiment, right? If we put people in an active war zone where they're concerned about their day-to-day survival and on a very real level, that's kind of a pretty big trauma and a pretty big trigger to wanting to escape those emotions and those feelings, and drugs can do that. So let's go back to rat park. So then he said, okay, now I'm going to get some rats to develop a substance use disorder. So I'm going to put them in an isolated cage for 57 days and then put them in rat park with a bunch of rats that have like grown up and lived in rat park the whole lives. So those rats went through withdrawal, but recovery happened. They actually ended up reducing their use and avoiding, and this one he used morphine. So in general, the consumption rose, but it was still less than those isolated rats. So it was less than people who had lived in a like nice, happy society. More than people who lived in a nice, happy society, but less than the people that are the rats that were in isolation completely. So what does that mean? Like, how do we translate that into humans? So one way to look at it is if we prescribe somebody and we get them good and physiologically dependent, not necessarily developing a substance use disorder, but they have a major surgery, you can become physically dependent on opioids in as little as 7 days. Well, 3 days. 3 days and you can have some withdrawal symptoms. 7 days and you can have the classical withdrawal syndrome. So think about, if you have a big surgery or, so you have a bad injury and they prescribe you opioids for even 3 to 7 days, you can still have withdrawal. But not everybody who has withdrawal has a substance use disorder, right? Not everybody who has a hangover has an alcohol use disorder. Fair? So what happens, so we can start opioids, and if we do that carefully and we do that in a structured way and we support people as they come down off of them and we use what we call alternatives to opioids to minimize the amount of opioids that we're using, people can be very successful. We just have to remember that opioids are very powerful medications and we do have to be careful with them, as we do with kind of any sort of controlled substance, right? So there are some social risk factors that and social markers that show that increase risk. Okay, another choose your own adventure. You guys ready? I ask really hard questions. There's definitely right and wrong answers, and we are taking notes because those of you that answer wrong are not gonna. No, I'm joking. So what do you think? How old do you think somebody is on average when they first start using substances? Yeah. 12. Any other guesses? Did I see it here? 13? 14, 12, 14, 16, 11. Despite not being 11 years older than when my son was born, I have an 11-year-old. It's pretty remarkable how that math works. But he somehow is aged faster than I do. Confident. I have an 11-year-old and I look at that kiddo and I'm like, whoa, that's really scary. And if average is 11, what does that mean? People are younger than 11 when they use, right? For the first time. So one of the questions I always ask my patients is, how old were you the first time you remember having a substance? And it's not unusual for me to hear something about somebody being 4, 5, 6 years old and somebody who should be a trusted adult in their lives, a parent, a grandparent, a neighbor, a family friend, offers them, a part of a pot brownie or a their active cigarette or a sip of their beer. And so we often talk about addiction also as a developmental disease, right? Before somebody is diagnosed with diabetes, they've usually have had creeping up their blood sugar levels, right? Over the course of 10 years. And it's similar with addiction. Often it's not that somebody kind of like woke up one day and had a substance use disorder, just like they don't kind of wake up one day and have diabetes for the most part, right? These things kind of develop over time. And so when we look at an 11-year-old, when I look at my 11-year-old, like your brain actually develops from back to front. You guys are almost there, I promise. It doesn't finish. Your CEO of your brain, your executive function of your brain doesn't totally finish developing until you're in your late 20s. So you're almost there, I promise. Almost so close, so close. So your front, so I tell people that like I am my children's frontal lobe, like I am their CEO, right? Like at 11, he doesn't have a lot of choices, right? I have a 9-year-old too, but she's not 11, so she doesn't get the attention right now because she's not the average age of first use. So I'm less like obsessed with her right now. No, but right. So we look at, when I look at my 11-year-old and I think about all the terrible decisions he makes on a regular basis, I'm like, thank goodness you have me to be your frontal lobe. But when we think about a child that is, 11, even, 16 years old, and they go to a party, or they're exposed to an opportunity where they have the choice to try a substance or not try a substance. Some of it depends on what are the pressures around them. Are they really able to say no? I mean, I have a very distinct memory of sitting on the kitchen counter at 12 years old. I'd had a bad day at school and my mom gave me a shot of vodka. She was like, this will make you feel better. And at 12 years old, I didn't think to tell my own mother no, right? So sometimes there's choice and then there's choice, right? But a child who uses at age 11, at age 9, like my daughter, we'll throw her in the mix. That's scary too. Just have all the scares right now. But a child who uses a substance voluntarily at that age is showing a risk-taking behavior, right? They're willing to try that marijuana brownie when they're offered it by a friend, right? They're showing a risk-taking behavior. So you've probably heard of marijuana as a gateway drug. It's not a gateway drug in the sense of like, if you use marijuana at 16, you're going to be using cocaine at 19 and injecting fentanyl at 22. It doesn't really work like that. But that use of marijuana is kind of a risk-taking marker. And if you're willing to take the risk of using marijuana, you're more likely to be willing to take the risk to try cocaine, to try fentanyl, to want to stay up late to study for that big exam and take your friend's Ritalin. That also is illegal drug use, right? But we don't always think about it that way. So we also live in a culture that is more connected than ever electronically. I'm old. So what's like, I don't do social media. I'm on LinkedIn if you count that, but I don't even know if that counts. I have a staff member who manages it for me because I epically fail at it. Even when she's like, here's the post, copy and paste. I'm like, sounds really scary and intimidating. So they just kicked me off of it because I didn't do a good job. But when we think about social media, we think about it as a way to socially connect with people. It's got social in its name, right? But we actually, what the growing body of evidence shows is that these social media platforms actually increase the risk of isolation, increase the risk of mental health concerns, increase the feeling of isolation. They don't connect us. They make us feel worse about ourselves. And I am like the type of person that would feel obligated. Anyone else like that? Like you feel obligated to like respond to people or do something with it. Like, so that would just be really dangerous and a huge time suck. And I just don't have time for that. So I'm really glad that I am one of the less than half of the people in the world that has never had a Facebook account. I'm very proud of that fact. So humans have a need to bond and form connections. We need this three-dimensional space. I love you virtual people, but we need this kind of three-dimensional in-person connecting with each other. It is much more impactful It does different things to our pleasure reward center. We have one pleasure reward center. So who in the room is my brave lactose intolerant person? It's got to be okay. Oh, we got a couple. Okay, I'm going to pick on you both. Okay. If I came in with a tray of ice cream sundaes, what would be your response? I know, really hard question. Do you want it multiple choice? I can do multiple choice. What's your response? Do you want an ice cream sundae? You would turn it away. Back of the room? You'd eat it. Okay. The pain is worth the gain, right? That's one population of people. The next population of people is the people that are like looking in their bags to see if they have Lactaid. The pain is only worth the gain if she's got Lactaid in her purse. She's going, see, there you go. The pain. So you're the pain is worth the gain. You're in the second group. Keep the Lactaid just for emergency purposes in case there's ice cream. And then you were like, no way. Like, nope, don't want to deal with that. Don't ever want to touch it. I tell people that my husband is lactose intolerant to opioids. So when we had our second child at 10 days post delivering the child, like my body had just opened up and expelled a human, like quite literally. My husband had a vasectomy. So I took him, I told him I would have my tubes tied if he would love it, if he knew how many people I told this story to, but he doesn't need to know those things. We'll just keep that between us. So I told him that if I had to have a C-section, I would happily have my tubes tied, but it is a lower risk procedure to have a vasectomy than to have a tubal ligation. He can't argue with that because he's a software engineer. So I'm just going to show him the numbers and be like, I'm right, you're wrong. So took him for the vasectomy and we came home, right? Like we had a 2-year-old minus 3 weeks and a 10-day-old. And I said, honey, go rest. Go rest. You just had a vasectomy. You go rest. I just like opened my body and expelled a human, but I got it. We're good. We're good over here. So he went into the bedroom and he rested and he came out a few hours later and he was like, I don't feel very good. And so being a physician, I was like, well, what's going on? What was the onset of the pain? Where is it? How is it? Like, what's going on? He was like, no. He's like, I took that medicine from the doctor and then I threw up. Apparently throwing up while you have testicular pain is not a pleasurable experience. So he is not going to become addicted to opioids because opioids make him feel crummy, right? Whereas like me, they make me feel great. Like I can, like you give me one and I can like do 7 loads of laundry, meal prep for a month, clean the whole house from top to bottom, like scrub the grout. I don't know what else do we need to do. Right. And like, so my brain clearly lights up differently than his does. So those kind of genetic changes, and we can get into like epigenetics, which is sometimes is like what the exposure was when you were developing. It's remarkable. But we know that there is a genetic portion to addiction and then also a kind of exposure portion to addiction. And what this is a quote from Dr. Alexander, and it really talks about we really need to talk about social recovery. So how do we bring people together? How do we decrease isolation? And I think in this kind of post-COVID world where we have an opportunity to rethink through what that means and what type of things are going to help keep our communities as safe and healthy as possible. So I'm going to transition. Don't worry, there's a clock here. So I've got a timer, but really it's football. I would be way more inclined to stop on time if it was hockey. Let's just be really honest here. I mean, I don't know about anybody else. Football, I'm like, you got to get 4 yards. Is it 4? No, you got to get 10 yards in 4 tries. That's the right one, right? Is that right? Did I get it right? Okay, yeah, I got it right. Yes. We do music in our house. It's okay. We only practice piano on the days that we eat in my house. Flexible parenting. So we're going to talk a little bit about advocacy. So I want to get you guys thinking about maybe topics that might be of interest to you. It doesn't have to be healthcare related. It doesn't have to be addiction related, although I'm going to talk through kind of an addiction example because obviously that's the world I live in. So are there things that just kind of bother you? Do you have a gut feeling like something happens and you're like, ugh, that sucks. And that sucks every time. Do you have like Do you have experiences that you know should or could be different? And are there, when I talk to healthcare providers, I talk about barriers to allowing us to provide kind of high quality, the kind of care that we really want to provide to our patients, and kind of like what keeps you up at night? What are the big social dilemmas that keep you up at night? And so why is advocacy important? We can, as healthcare providers, as future healthcare providers, you can lend a lot of credibility to topics. People are very respectful when you come and you're a student at, you're a student at a university. You're not just, you are like, you have some expertise, even though it doesn't always maybe feel like you do, but that you are very powerful. The most common, what is the largest population that votes in the United States? People age 65 and older. So our legislature and our community, our community, our county commissioners and, both a local, state and a national level are usually actually really excited to hear from somebody who's young. So they're getting there. I'm already starting to get like stale over here. I'm like, so they're often really, really excited to actually hear from you. And I do want to point out that like when I do advocacy, I actually don't always want to speak to the senator. I'm like, great, nice to meet you. Okay, where's your health policy staff person? Or where's your chief of staff? That's who I want to talk to, because those are the people that actually do like the boots on the ground, the drafting of policy, the drafting of laws, the communication between offices. And so sometimes people are like, well, I didn't even meet with the representative or the senator or the county commissioner. I'm like, no, you met with their staff person. That's actually a lot of times, if not always. I'm trying to think of a time where it wasn't better than actually meeting with with the actual legislature. Because usually like they'll be like, my office will follow up with you anyway. So like you might as well just go right to the office, to the staff. Advocacy can start small. It can start on a local, it can start on a classroom level, it can start on a university level, it can extend out into the greater Marquette area, it can extend out into the county, and then it can extend out into the state and the nation as well. But nothing is too small to do, because whatever you do from an advocacy standpoint is going to hopefully positively impact the people that you're trying to serve, the people around you, right? And advocacy for me gave me a lot of a sense of purpose. I like having that kind of broader impact. There's a lot of power to sitting in an office with a patient, talking to them one-on-one, but sometimes it's kind of neat to think about kind of that population level, that public health level impact that you can have when you work in advocacy. And it's a really great channel for systems frustration. So like when you see like a campus rule that just kind of doesn't like, it just sucks, right? I mean, we all have those. We're not perfect. Some of them are also just older, right? Then that is a way to kind of positively channel your frustration with some of those things. So where do you begin? Like, okay, so nothing's too big, nothing's too small. Great, but how do I start it? So I tell people it all starts with a cup of tea. So get cozy with your why, define your goals, figure out what the story is, what brought you here, why do you care about it? Refine your message so it can be like an elevator speech, no more than 2 minutes, because you lose most audiences by the time I've been talking as long as I have. And just never give up. I tell people all the time that like, I just didn't stop talking about advocacy and what mattered to me. And we'll go into that's a specific example on that. Sometimes it takes years. It took 7 years for me to get my first like big success in advocacy. So there were lots of times that I was like, am I doing anything? Is it helping? Am I wasting my time? But you just, sometimes it just takes time. Just try, like, just do something, you can write a letter to your local representative, your county commissioner, the chair of a department, and just see, kind of see what happens. Ask for conversations, start small, look at your local environment, and then make sure you measure success in different ways. So it's not always about getting that big win or getting that huge policy change. Sometimes it's as simple as somebody telling you that they hadn't, considered looking at the disease of addiction as a disease and not as a moral failing. And if I can change one public policy person's view on that, whether it's a staff person or the senator, right? If the staff person now is looking at it differently, then they're going to message that differently to the senator, right? Or to the representative or to the county commissioner. I'm just picking on the Senate. I don't know why. So I'm going to give you this. So that's kind of the broad overarching kind of theme. And so let's talk a little bit about why, what I do and why I do it. So it's sort of hard to like pinpoint why I do what I do. Like if the tables were flipped and we went, back in time to when I was an undergraduate student, like most of you probably do, I had a lot of plans. And if you had like pulled out a crystal ball and said, hey, you're going to be an addiction medicine doctor and you're going to, come up to Marquette and you're going to speak to these students and you're going to talk about, all these fantastic things and fun things that you get to do with your life, with your professional life. And I would have been like, no, that's crazy. That's just ludicrous. When I was applying to medical school, I have a condition called alopecia. I don't have hair. And I thought I wanted to go into dermatology. And then when I was in medical school, I did a dermatology rotation and I was bored. Like that, this sucks. I lost my hair when I was 5. So I tell people I never actually lost my hair. I just was like, I grew up as a kid that didn't have hair because I don't remember having hair. I do remember crying because my mother was cutting my brother's hair and I saw scissors to my brother's head. I didn't realize that he just didn't want to sit still. I thought my mother was cutting my brother. I was like 8, cut me some slack. But life sometimes throws you curveballs and you kind of have to take what you can. And so before I started medical school, my mom was diagnosed with a rare kidney disorder. She lived about 7 years with it, and she died when I was in kind of the late stages of my training, doing something called a chief residency. It was actually on the afternoon of the day I saw my son's heartbeat for the first time on ultrasound. I also have a bunch of hormone problems, and so after 2 years of fertility treatments, I found out I was successfully pregnant that morning. When she died, I was actually leaving an end of life discussion. I call that a lemon moment in my life. It was sort of heartbreaking, right? I heard from a lot of people, it's the circle of life. And I wanted to tell them, no, it's not the circle of life. The circle of life would be like if my grandmother died, if my mother died. Who do you want when you're pregnant? You want your mom. But women in my family, we don't live like that. My mother was 52 when she died. My grandmother was 64 and my great grandmother was 32. So like life expectancy, not looking great for me. More lemons. So I had my son, I had my husband, we were creating something together. I at that point interviewed for my addiction fellowship, actually 3 days before my mother died. My baby and my pregnancy and my relationship with my significant other. 7 months later, my son was born, a healthy baby boy. And so there's kind of the sugar to make some lemonade. And so that's my mom's gravestone. And in the middle of my fellowship, you see that other one on the left of mom? That's Max. That's my baby brother. 17 months and 1 day after my mother, 10 months and 1 day after my son was born, my brother died of a self-inflicted gunshot wound to the chest, secondary to his longstanding alcohol use disorder. He was 24. He had graduated from Michigan State University, and he had started law school 18 months prior to that. So I got another good dose of lemons with that one. And so I being me, was kind of determined to make my lemonade. I tell people that each day kind of kept coming and each day kind of hurt differently. But from this is where I really started to grow my purpose. I was already on the path to being an addiction physician when he died, but It really changed into something that I really grew my purpose from. I started speaking publicly about Max, about my mother, about my story, and I learned about. And we moved back to Michigan after my fellowship, and I learned that in Michigan there were some gaps in Medicaid coverage. My brother was actually never offered FDA-approved medication to treat his alcohol use disorder. And as his sister, I will always wonder every day until the day I die if my brother had been offered FDA-approved medications to treat his alcohol use disorder, if he would still be alive today. And I get to live with that every minute of every day. On average, we provide 9% of the care that a person with an alcohol use disorder needs through the healthcare system. 9% of what the evidence shows is likely to improve outcomes to improve their health is what we provide to them. So I started talking about this. Every time I spoke to someone in the state government, I would tell Max the story. I'd tell my story. I started making connections. I tell people I would like talk to anyone. I'd be like coming out of the YMCA and be like, did you know Medicaid doesn't cover alcohol use disorder? I ended up being appointed by the governor's office to the Board of Medicine. I was on our current governor's transition team. I spoke at a press conference with the governor. I spoke to colleagues. I spoke to friends. I spoke to anyone who would listen. Doors closed. People said no. I looked for wedges. I looked for other people that were, interested or at least willing to answer my emails or phone calls. And I just kept trying. I had to. I mean, Max was more than that, right? He wasn't going to be one on a list. He was going to change something. And I was going to be the vehicle by which to do that. My daughter's name is Eleanor Rose. We get one guess. Do you need to guess where she got her name? Nice, strong, public health minded woman. I don't know. Anyway, so I kept talking. I tell people I would look at my daughter, my Eleanor Rose, and I would remind myself that she deserved a better place to grow up in. She and her older brother deserved a world, or at least to grow up in a state where their uncle didn't have to die, where there was hope for the future. So I kept talking about it. I never gave up for 7 years. I endured. I never stopped talking about Max and the need to change Michigan's Medicaid coverage, and now refer to it as my 7 years war. For anybody else who enjoys history, the 7 years war was a turf war between Great Britain and France over colonies. And so it was kind of like that with this policy. We have a behavioral health carve out in the state of Michigan. And so the Medicaid HMO plans, the healthcare plans, said, no, this is not our responsibility. And the behavioral health carve out plan said, no. The PIHPs or community mental health said, no, this is not our responsibility. And they sort of did this. I was like, well, wait, somebody has to do this. And so it's actually an exception. It's billed through a separate method. It's a little wonky. Because of this behavioral health carve out, and because of this dichotomy, in 2014, initially they opened up limited services for a single diagnostic code. If you're wondering, was F11.20, which is opioid use disorder. From 2014 until 2020, I continued to advocate. And then in the summer of 2020, I received a request to review a policy from Medicaid. And I was like, what? It was my policy. It was like what I've been asking for. And so a year later, it went into effect on August 2nd of 2021, in case you were keeping track of the timeline. We're going from 2014 to 2021. So it was about 7 years. It was kind of my 7 years war. If you notice, this specifically calls it alcohol use disorder and opioid use disorder. So there is still no reimbursement to see an addiction physician for any type of physician, not just an addiction specialist, for any other type of substance use disorder. So I'm going to skip over these slides. I just decided I'm just going to skip. Okay. We're going to talk about the Michigan Opioid Advisory Commission. So the Michigan Opioid Advisory Commission is over that $1.45 billion. It is part of the Legislative Council, which means we sit in the legislature. Okay. And what our role is we are supposed to advise the legislature on the spending of the national opioid settlements. And this was litigation that involved the manufacturers, distributors, and marketers of pharmaceutical opioids that resulted in multiple national settlements. And Michigan, as a state, our attorney general decided to sign on to the national litigation. Some states continue to do individual state by state litigation. As of right now, the ones that are kind of in the tealish color are the ones that have been settled and we are actively receiving payouts for. And the ones, and the ones in white are different, are at different levels of litigation, but there have not been payouts for them. So different states do this differently. So we're just going to talk about Michigan for any out-of-state students. It may be different where you are originally from. So Public Act 84 of 2022 developed the OAC, and these are our general, the general expectations that are laid out in law for what we are supposed to be doing. So reviewing strategies to abate the opioid crisis. It's important to note that this money can be used beyond just opioids. It's really abating the addiction crisis more broadly as well. Establish priorities to address substance use disorders as well as co-occurring mental health conditions. And then recommend funding gaps. So this money is not to be used to supplant existing funding. It's not to be used. It's to be used to identify and insert insert kind of plugs in current gaps in what we are doing as a state. So we report directly to the Senate Majority Leader's office and the Speaker of the House of Representatives. And then you can see that we're required to send a report to that leadership as well as to the Governor, Attorney General and the chairs of the appropriations committees. And so we take this charge very seriously. We have, there are 12 commissioners on the commission. Kyle Rambo, who's the executive director of Catholic Social Services, represents the Upper Peninsula, and he's Marquette based as well. So you do have a direct link to the Opioid Advisory Commission here in your community. So the two public acts that created us are the ones that are kind of guiding documents for us because we have to do the things that are in there, or I'm breaking the law. I try not to break the law in general, although it was real hard not to speed earlier today. I'm just saying that. And then Exhibit E is kind of the National Opioid Settlement says that these are the things that you can use the money for. It's the document that says it has to be used to fill gaps. You're not supposed to spend it on things like law enforcement. Ideally, you're supposed to spend it in some buckets, and we'll get to those as well. And then there is a spending principles document from Johns Hopkins Bloomberg School of Public Health as well. The Bloomberg Hopkins spending principles are: we want to spend money to save lives. We want less dead people. 8 people die in Michigan every day from an opioid overdose alone. That's like, we're going to say cardiovascular deaths. We are only going to count the people that die from an acute heart attack, like a massive heart attack. We're not going to count the people that die of like kidney failure related to their hypertension, or from a stroke related to their vascular system. Cardiac deaths are going to only be counted if it's an MI. Because what we're not talking about is we're not counting the people that die of infectious disease related causes. We aren't talking about we've done a really bad job as addiction and portraying the magnitude of it, because usually they talk about all cardiovascular causes, the cardiologists do. And we're just going to talk about opioid overdoses. More than double that number of people die every day from alcohol related causes alone. If we put together smoking, alcohol, and nicotine related causes of death in the United States as a whole, it is by far the leading cause of death. Everybody else takes credit for addiction related causes of death, like COPD. Addiction caused, right? Nicotine, smoking is the most common reason that somebody develops COPD. Most common reason for delirium in the hospital-based setting, alcohol withdrawal. Most common cause of liver cirrhosis, alcohol use. I got it all, man. I got it all. So we need to spend money to save lives. We need to use evidence to guide the spending. So we don't want to use opinion-based science. We want to use evidence-based science. We want to invest in youth prevention, things that actually work. The number one thing that is most proven to reduce to reduce substance use in youth is big sip, little sip programs. Not even talking about addiction. Big sip, little sip programs. What do big sip, little sip programs do? What do they decrease? Isolation. What do they increase? Community. The feeling of belonging. So for any of you that are volunteering in high schools or with youth, you can totally spin that in a medical school application to be absolutely healthcare related. You're facilitating healthy mental health in the youth that you're working with. Sorry, that was a total application side note. Focus on racial equity. Racial and ethnic equity is how we've interpreted that, and develop a fair and transparent process for deciding where we're going to spend money. These are our big buckets: prevention, treatment, recovery, and harm reduction. And then these are the guiding principles that we've developed. So those are our buckets, and these are things that permeate throughout all four of those buckets. So health equity, cross-system collaboration, whole person care, and service innovation. So we have an annual report. You can go on the OAC website and you can download it. It is really great if you're having a lot of insomnia. Might help you fall asleep. So here are the key takeaways, so you don't have to fall asleep reading the report, but honestly, I spend a lot of hours writing the report, so it'd be really fun if I knew actually people read it. But our key takeaways are: we want to increase public transparency around the management of the state share of opioid settlement funds, and expand community engagement and inclusion, and enhance collaboration and increase legislative oversight. We've been able to get some, this year's appropriations does have some requirements for reporting that previously weren't in there. So we definitely know that we are having an impact. Here are some of our next steps. One thing that's happened is this money has like state shares, and then it has local shares. So if you go to the Michigan Association of Counties website, they have a dashboard that will tell you how much money your county received. Your county, usually it goes through your county commissioners, but often they're kind of sending that to the health department to decide what to do with it. And so really elevating that kind of community voice. So what Marquette needs is probably different than what Kent County needs, right? Where Grand Rapids is. So how can we make sure that we are developing solutions that are appropriate for the communities that we have, not for, and not trying to kind of do a one size fits all blanket for everyone. There was a separate tribal settlement, but the state settlement dollars can be used to support tribal populations as well. And they've been largely ignored in some of these state-based conversations. So the Opioid Advisory Commission is really trying to integrate tribal voices into the advisory space, so that we can make sure that we're serving all of the citizens of Michigan and not kind of choosing who we're going to serve. We are implementing quarterly progress reports. Our first one will be released in October. So hopefully mid to late October is our plan. And so here are some of the things that you can do. So we talked about identifying your local leadership structure, initiate contact to express interest in whatever it is that you're interested in, maybe in the opioid settlement dollars, raise awareness for what matters to you in your community, and contact your state representative or senator. The Opioid Advisory Commission will, when we release kind of this packet of information in October, there will be a like template letter that you can send to your state representative and senator to kind of say, hey, this matters to me. And that would, help us make some noise to encourage responsiveness from community leaders, decision makers, elected officials. Outline your asks and follow up with them. I end all of my talks to all of the people that have lost their lives to addiction and to those that try to prevent further losses. Thank you so much for taking time on a Thursday night to hang out with me. It's been my pleasure to be here today. I meant to leave 5 minutes. I left 3.
Well, first off, thank you. Just curious, I worked with it seems like a big challenge. And for me, for people, department, and it was showing integration into for people that have like, and it's hard to integrate them. Like it's hard to like medication they need, oh the neighbor or the community, like vulnerable.
So I'm just going to kind of repeat for the online folks. I'm well trained. See, I'm well trained like a circus monkey. So the question is essentially for vulnerable populations like homeless individuals that also have a substance use disorder that may struggle with the reintegration process into kind of the more mainstream society. What can we do to support them, and how can we help them? So that's where kind of that harm reduction idea really comes into play. So we have to meet people where they are. We have to find out where they are and how we can support them as individuals, and that and that may not necessarily mean that they're ready for addiction treatment. That may mean that we want to keep them alive, right? We can't. I always tell people you can't get a dead person into recovery. It's just a fact. Right. And so how can we support them and keep them as healthy as possible, as safe as possible until they're ready to enter treatment? And so so we use a lot of something called motivational interviewing. And really what that premise of that is finding out what matters to that person, what is kind of ego dystonic, what doesn't make sense, what is something about the behavior that they're displaying that maybe doesn't match with what their actual life goals are. And so it's really about finding what that individual wants in life, because we may think that being homeless is not an ideal situation, but for some people that is where they're comfortable and they don't want to be in a home. We also have a lot of stigma around creating safe spaces for people to live if they're actively using substances, because the problem is that when, if an organization comes in and they say they're going to start a home for people that maybe are unhoused and are not currently interested in addiction treatment, people say, not in my backyard. Same thing happens with things like methadone clinics, right? Not in my backyard. I don't want those people here. And it's not really those people, right? If we take out nicotine, 1 in 7 people in the United States has a substance use disorder. So I'm just going to say there's more than 7 people in this room. I don't know if that fully answered your question. Thank you. Oh, you got a microphone now.
Oh,
there we go.
okay.
We're official.
Wow. No, I just had my wisdom teeth taken out, and my dentist gave me 50 pills of Vicodin.
That's insane.
I took one
Mhm.
and said, never again. This is insane. I don't even see how some of these are legal or how they got approved.
So like I said before, some of these medications are very powerful, and we have to respect them for the power that they have. So in probably the last 5 or 7 years, there's been a big push to reduce the amount of prescribing that happens. So it's actually, there's this other school downstate. I don't know if you've heard of it. It's University of Michigan. They have this program called the M-Open, where they actually they're actually good friends of mine and colleagues of mine. But I have to joke, or I wouldn't. I mean, I get dressed for these things. Do you see the theme here? So ignore the jacket. No, where they actually went and they called people after things like wisdom tooth extraction or other procedures. And if you go onto their website, they have prescribing guidelines that talk about not prescribing as much, because what you said is exactly what happened. They would call people and they'd be like, so you got your wisdom teeth out. How many of those Vicodin did you take? Or how many of those Norco did they take? And people would say, 1 to 3. And so they kind of tallied that information up, and they were able to reduce reduce the amount that was prescribed. Probably 10 years ago, I used to be, there was a statistic that kind of everyone sort of quoted that 80.2% of people who had a heroin use disorder, this was before the era of fentanyl, that they had started with prescription opioids. Thankfully, that has largely changed across the nation, but certainly in Michigan as well, as we've seen these kind of alternatives to opioids or other pain management strategies. But I think it comes down to really respecting the medications, the power that they have, and being careful and judicious. Like if you go to England, you can get Bayer pharmaceutical heroin. It's used in end of life care. But you can actually, it is a pharmaceutical. So it's some of the like legal, not legal for some of these things is a little bit of a somewhat artificial construct.
At one online, and then we'll go to back to the front. How's the Opioid Commission maintain transparency and accountability in how the dollars are being spent in each county, especially since reporting isn't required currently? Do you think there are enough safeguards to prevent a repeat of tobacco settlement dollars?
It's a real short answer. No. I have a lot of concerns, which is why I ask people to write letters to their senators and representatives to change some of that. So in the Opioid Advisory Commission, we're over the state portion of those dollars. We're not responsible. The Attorney General's office is the responsible entity for the local distribution. So you can email the Attorney General's office about questions about how they are planning to adjudicate the local spend of dollars, but there is no formal reporting requirement. And we are working really hard as the Opioid Advisory Commission to elevate the principles of transparency and community engagement with exactly that intent, to put pressure onto state and local officials to ensure that the money is used in a safe and effective way. There are some safety gaps put into how this legislation, how these settlements were created, that is different than the tobacco settlements. So like the money from the tobacco settlements, if it was appropriated by legislature and it was not spent that year, it would go into the general fund and could be used for anything. And so this money, if it's not used in a year, it goes back into the Healing and Recovery Act developed fund that is statutorily required in the second of the two laws that I mentioned, for our state, to ensure that the money at least is used. I will say that I have not been I have not personally felt as though the Department of Health and Human Services has been as transparent as I would have liked in terms of how they are using that money and how they are determining what gets appropriated to who and why. And that is a huge part of the advocacy that the Opioid Advisory Commission did in this last budget cycle. And we were able to get a requirement for semi-annual, so twice a year, reporting on those dollars to help us better ascertain how they're working. And we continue to work with our leadership to develop ways that we can encourage transparency or potentially appropriate those dollars through a different vehicle.
Great. Let's take one more right up front here.
I've just met like a few people that talk about like when they're the ropes of addiction, of spending like a large amount of time, of course, trying to like obtain their substances, which you almost think if it could be better used, them like having their substance, engaging with healthcare providers, and then trying to work off of it. But do you have any opinion on programs like I know in Britain, or I think Canada, where people get controlled use of drugs, like hard drugs? Do you think that's like efficacious?
So safe injection facilities that people can either bring their own substances or can obtain substances. They also have like testing to see what sort of adulterants may or may not be in the substances. And then they have healthcare providers, nurses, physicians there in the event that somebody overdoses. It is proven to be efficacious in terms of reducing overdose deaths. It's also proven to be efficacious in terms of engaging people in care. So that, it's sort of it's a bit of a trust, it's a trustful space. So when somebody then is ready to engage in treatment, they may come to that organization to access kind of more mainstream healthcare. They are technically currently illegal in the United States, although there is a safe injection facility in New York City. So they are growing in they're growing in popularity. I think the corollary other question that you have is a little bit about the legalization of substances. And so if the country that everybody goes to is Portugal. So Portugal legalized recreational doses of substances. So if you're found with a recreational amount, then you're not prosecuted. However, they don't just not prosecute you. They try to engage you into healthcare services. And after so many, after so many times, you can technically be mandated to treatment. They also took them, like if we took the money we spent on the carceral system and we put it into addiction treatment, that would be helpful. But if we legalize substances and then we don't put that money into treatment, into public health resources, into kind of community, the big SIB, little SIB programs, the prevention programs, or if we don't take that money and use it to address the addiction crisis in the United States, and instead we use it on, something unrelated, infrastructure builds, then that's not going to help us with the addiction crisis. So if we're going to do things like that, we need to make sure that that money is then pigeonholed to prevent and treat substance use disorders. My personal opinion. Thank you. I know we went over, they're going to hate me. They only have 6 minutes.
No, you're fine.
Is there like a student lounge in here? I don't know.
Yeah. So I want to thank you all for those who came in person and joined us online. I want to thank our hosts, Northern Michigan University, as always. Thank you for having us, and our other co-sponsors, Michigan State University College of Human Medicine, UP Health System Marquette, and Superior Health Foundation. And let's give Dr. Poland one more round of applause.
You got 13 hours.